lot to get through to end us off. This stuff is, I feel like, more interesting because it is more nursing problems, nursing things that we'll see in practice, all that good stuff. So this stuff will kind of move a little quicker than the just background mental health information did. But we're going to talk first about neurocognitive disorders. Now, the thing with neurocognitive disorders is that these are the disorders which it basically says when you do have that deficit or you're deficient in cognition or your memory. Now, why are these important, or why do we need to study them? Well, we have this aging population. We have more of our population that's reaching the age where neurocognitive disorders are more prevalent and seen more often. So since we have a society that is getting older and older, then we do need to address how we're going to take care of some of the problems they will face. And a lot of that is going to deal something, or sometime or another, they'll have some form of neurocognitive disorder. So we need to know what they are, how to differentiate them, and how to treat these patients and what interventions we're going to be doing. So we're going to spend some time talking about that this morning, or this afternoon. So let's first talk, well, before I keep going, so remember I talked to you about the DSM-5? You remember me talking to you about that, the diagnostic manual? Well, in the DSM-4, so the version before this, these disorders, the neurocognitive disorders, used to be referred to as delirium, delirium, dementia, and amnesic disorders. We don't really use the word dementia anymore, or amnesic disorders. Those are kind of now a thing of the past. And with this new book and the new edition, these disorders are referred to as delirium, which we're going to talk about first, and then mild neurocognitive impairments or disorders, and then major. So now they're distinguished between mild and major neurocognitive disorders. No longer are we using dementia or amnesic disorders. But okay, and in general, when we're caring for people with these neurocognitive problems, our goal is to keep them at the highest quality of life that they can have, that is attainable for them, to preserve that quality of life that they do have, and to give them guidance and support, along with giving guidance and support to their family or their caregiver who's going to be impacted by their disease process as well. Okay? So I told you the first thing that the DSM-5 talks about is delirium, so let's talk about delirium first. Delirium, I know some of y'all, we've talked about it, but delirium, the big things about delirium that distinguish it from mild neurocognitive disorder and major neurocognitive disorder is that abrupt onset. Develops rapidly over that short period of time. Again, when I think of delirium, I think of short-term and reversible. Unlike your mild and major neurocognitive disorders, delirium is more of a reversible type of disturbance in your level of awareness and your cognition. Again, it can, you see this fourth bullet point, it can have a slower onset. Typically that is only going to be with your more systemic illnesses. If those are the underlying root causes, you won't see such a quick and sudden onset of this delirious state. But more times than not, you'll see this abruptly be caused by, a lot of times, seizure can cause it, drug withdrawal, overdose, hospitalization, head injury. Otherwise, when it's not that rapid onset, it can take several hours to days to occur. Again, that's typically more with a systemic illness or a metabolic imbalance. Now, typically your duration, like it says on this last bullet point, is going to be very brief. Most times your symptoms will diminish within 3 to 7 days after you've eliminated the cause. Now, the big thing is, if you're not eliminating this cause of delirium, delirium can progress to a more permanent and a more non-reversible type of cognitive disorder. How well your client does with delirium, if they do develop delirium, does depend on their age as well. So age does play a factor in their rate of how well they resolve their delirious state. All right. I also give you some symptoms, and I like to give symptoms sometimes because I want you to see, like, and be able to picture this patient in your mind or this client in your mind, what they might look like and what they might be presenting with. But you see there's a lot of different things, and you can kind of have one end of the spectrum to the other. You can have somebody who's very hyper alert, hyper vigilant, to somebody who's almost coma and stuporous-like. Again, they can have interruptions in their sleep-wake cycle. They can have hallucinations. Emotional instability, that means that, they can be anything from apathetic to very angry, very hostile. But again, these are some of these things you might see with somebody who is delirious. Now, there are some predisposing factors to delirium and things that cause it. Sometimes it can be due to a medical condition. You've seen this in infants or younger people too when they have that febrile illness. When somebody's fever gets too high, they can become very delirious from their temperature getting too high. Again, once you give them Tylenol, Motrin, something to cool them down, that delirious state should resolve. And you see infections is one. What's a big infection that causes delirium? UTI in your elderly population. I can't tell you how many people you'll see in the ER that come in that are not, their altered mental status, family thinks they might have had a stroke, when in reality all they have is a really bad urinary tract infection. But you can see how much those can alter somebody's state of mind when an infection gets too bad. And I told you about seizures, strokes can do this too, head trauma, and you see some other examples as well. You can also have that substance-induced delirium, either from intoxication or withdrawal, from different medicines, from alcohol, also from like lead and mercury. Those toxins can cause it as well. One of the big predisposing factors to delirium, again, is going to be age. The older you get, people 65 and older are considered a high-risk group for developing delirium. So again, when your population develops any of these things or has any of these things going on, any of these medical conditions or substance-induced problems, then they're at a greater risk for experiencing delirium with those as well. Okay? So now let's move from delirium to our mild and major neurocognitive disorders, okay? Again, neurocognitive disorders are a little bit different in that typically with them, as opposed to delirium, these are things that aren't going to be reversible. They're going to be more stuff that's going to be slowly progressing. But there are differentiating factors between mild and major. The mild you see has also been called mild cognitive impairment. I don't know if any of y'all watch This Is Us, but that's what the Mandy Moore character has. She has the mild cognitive impairment in that show. But why you want to catch somebody in the mild neurocognitive disorder phase as opposed to the major is the mild one is the one where maybe you can slow the progress down or intervene and do things to help slow it down or prevent it from progressing to that major neurocognitive disorder state. The major neurocognitive disorder state is typically irreversible, and it was previously referred to as dementia. So again, you'll start seeing it now referred to as major neurocognitive disorder. Again, one of the big things we want to do is identify somebody with mild neurocognitive disorder so we can do early interventions to prevent or slow the progression of the disorder before it gets to the major neurocognitive disorders.
So like test-wise, we're going to see like mild NCD versus major, or do y'all still use the word dementia?
No, I still will use the word, no, I'm lying. I will use the word major neurocognitive disorder for testing. And I really just want you to know there's not really a lot I'm going to ask you on mild because we're not really going to focus on mild. But I will test you, on some questions that deal with some of the major neurocognitive disorders that we're about to talk about. So you'll see it referred to as major neurocognitive disorder due to Alzheimer's or due to Parkinson's. Okay, so you do have two different types. You can have a primary or a secondary. Primary is when it's organically caused and not from another illness. That's all we're really going to refer to with that is Alzheimer's. Secondaries are from some other kind of illness. So if you have HIV, if you get a head injury, if you have Parkinson's, something like that, where you can also develop a neurocognitive disorder. Some generalized symptoms with neurocognitive disorders you can see listed here. I'm not really going to go into major detail describing those either. But a lot of the thing is their personality change is going to be one of the common things you'll see. You can see even extremes of like whatever quality they had or personality they had is going to be maybe very accentuated or very heightened. Like maybe somebody who was fearful is now very, very paranoid. Or you can see like somebody who was very put together and well kept is now just so disheveled and not put together. So they can go from one personality to another, or they can just have the accentuation of their characteristics before they got sick. Now, you can have some language issues. Language, the more that your language is affected, kind of to me where I've seen it, it's been like the more severe the disorder, the more the language is affected. A lot of times you can see things like aphasia with some of the end stages of some of the neurocognitive disorders. But it can not be affected with some of them, but a lot of times it is going to be affected, especially towards the end and in the later stages, or if it's a very severe form. Now, there are some reversible neurocognitive disorders that you might really more often refer to as or see called temporary neurocognitive disorders. The only thing I'm going to say about that is that's very rare. Most of them are not reversible and are not temporary. And that is a very small percentage of them. But if you do have something like a bad B12 deficiency or like a folate deficiency, if you do correct that, then you can have, it can be one of the more temporary forms. But again, that's only a very small percentage of cases. In most cases, neurocognitive disorders run a progressive and an irreversible course. So let's talk about as your neurocognitive disorder does progress, like I was saying, you might start to see these symptoms, such as aphasia. What's aphasia?
That's like
Speech? What was speech? Not difficulty, they just basically can't speak. They can't communicate. They've lost that ability to understand and communicate or express their speech. So yeah, they can't talk to you. What about apraxia?
They can't control their movements.
Can't control their movements. No motor activities. Inability to carry out their motor activities. You'll also see more irritability and moodiness with some sudden outbursts over things that seem trivial. As it progresses too, you'll see a lot more issues tending to activities of daily living and needing help with their personal hygiene and personal care needs. And you'll see a lot of self-care deficits. Wandering away from home, you'll see that a lot too. What do y'all know, or what are some things that we do for patients or clients that wander? Not just away from home, but away in general. What are interventions we do as a nurse, or what do we teach families with clients who are sending home that might wander?
put like locks on doors and stuff like that, right?
Locks on doors, put them
Signs.
higher with a key that they don't, they can't unlock. What else? Never leave them alone is really a thing. Yeah, set them up with somebody to be with them. That's a good one. What else when they're at home? Night lights, yes, that's always good so they can see where they're going. a lot of them have the bracelets, some kind of bracelet to identify. You can teach them to do that, or even wearing something that says their name on it. Again, yeah, don't leave them alone. Safe environment. In the hospital, if somebody wanders, or even if somebody just has a neurocognitive disorder, what are some of the main things we're going to do to keep them safe? Because a lot of this is, again, I told you, you're just going to be keeping this client safe. So what are things you're going to do as the nurse when you have a client with this? Just on like a med surg floor.
Sit them close to the nurse station.
Always be close to the nurse's station, right? So you can see them. Make sure they know they're not alone if that's something. If they can't communicate with you, what are you going to try to do? Give them some kind of way to communicate, right? We're not just going to let them just go, oh, can't communicate, sorry.
Can you write?
Yeah, like, can you write? Can you point to what you need? Like, if you know, I can give you something. And keep that consistent with them. Keep them, like, within that consistent form of communication. Again, remove stuff in the room that might be, hazardous to them. Keep them to the nurse's station. But again, you see all these things, they're really going to be at a risk for an accident or a risk for safety, injuries, and all that good stuff. So we have to be thinking safety a lot of the times. And then with some of those too, we got to be thinking of their self-care deficits that they might have and then how we're going to address those as well. Okay, so now let's talk about some specific disorders. We're first going to talk about Alzheimer's. And I do want y'all to know Alzheimer's. I want you to know the stages of Alzheimer's and what happens in these stages. One of the big things you should know about Alzheimer's is it is a very prevalent problem, and it does account for 50 to 60% of all cases of neurocognitive disorders. Another thing I want you to think about when you think of Alzheimer's is Alzheimer's, depression and Alzheimer's kind of mimic each other. Depression in your older adult population can mimic Alzheimer's. So when you're assessing this clientele too, it's really good to get a good history and a good assessment, so you can try to distinguish between the two, because they can kind of present the same way. But Alzheimer's is going to be one of our most common form of our major neurocognitive disorder. And it does occur in more of a stage progressive-like fashion. It's not going to be something that's abruptly there in stage 7. It's going to kind of follow these stages, and the patient or the client is going to just gradually decline with each stage. Now in stage 1, you're not really going to notice anything's going on. There's going to be stuff going on in their brain, but you're going to not see that result in any memory problems. So their memory will still seem intact in stage 1, although they do have stuff going on in their brain that is not a normal occurrence. And then in stage 2, this is where you're getting that short-term memory deficits, where they'll forget things, like where they just place their keys. You'll see a lot of short-term memory problems. This is also a stage where you'll see clients who become anxious or depressed during this stage 2 because they're aware that they're forgetting things that they should remember. And they know that, I should know what this is, and it bothers them too that they're not being able to remember that. So you'll also see that you can start diagnosing in this stage. This is one of the stages where a family will notice potentially, or the individual will notice and seek maybe some help that they can't remember things that they feel like they should. Now when we get to this stage 3, the mild cognitive decline, if your client is still working at this stage, this is when it becomes obvious to not just family, but also to like close people they work with, like their coworkers, that something's going on. It's going to interfere with their work. Again, they're going to be forgetting a few more things. Their concentration might not be very good, or they can't concentrate as well on a task that they used to at work. This is a stage 2 where you'll start to see when they start to drive, they may get lost driving. Again, it's going to be more noticeable to family and those close associates with your client. And then you get to stage 4, the mild to moderate cognitive decline. In this stage, the client's going to forget some major events in their own personal past. And sometimes to cope with that, or as a part of denial maybe that's going on, they'll make up these huge elaborate stories, or make up just a story to fill in that gap in their memory. And when they do that, that's called confabulation. And we talked about this in another class, but a lot of times, like, people use confabulation, and sometimes, you know, we talked about how some of them had seen it in family members or clients that they've had where, you know, it calms them or it gives them that reassurance, or, you know, makes them feel a little bit better because they do have some kind of past memory that they keep maybe bringing back up or, you know, exaggerating into a more prevalent, you know, memory at this time. Or sometimes it is something crazy that's out of left field, but it's filling that gap and making that client feel like they're not, you know, something's not going on with their brain and they can't just not remember what they did yesterday. So, okay, so that's confabulation. And then stage 5 is the moderate cognitive decline. In stage 5, you're going to see the loss in their ability to perform a lot of their ADLs. We're going to need a lot of assistance with ADLs at that stage. They might also forget their address, phone numbers, names of close relatives. They're still aware of who they are, but they might be disoriented to a lot of the stuff around them, what time it is, or people, or the place that they are. Stage 6 and 7 is when you have that more, this is a more severe, and these clients need continuous help and need to be continuously looked after. Stage 6, you're going to see the moderate to severe decline where they're not able to perform any of their ADLs. They need assistance. A lot of times you'll see at this stage, when a client gets to this stage of Alzheimer's, the family will maybe have to have a permanent caregiver or put them in a place where somebody can care for them at all times because they're not able to meet any of those needs. You got a question? You used to always scare me when that thing would go off. But okay, at stage 6 also, like, you'll see a client who forgets who their, you know, significant other is if they're still married. So again, you can see how, you know, much care they would need and how much that would take up of a caregiver's time too. So it is a client who's going to need just some major help at most all the time. They're also really unable to sleep at this time too, at that stage. And then stage 7, that's typically that bed-bound aphasic state. Again, they're not able to communicate. You're talking, you know, the care where you got to watch out for the ulcers and all of that stuff to go along with it. Contractures happening with this client in this stage of Alzheimer's. Immobility at that stage as well is a big thing. But again, you see how this is a very kind of, it progresses from just the mild and moderate, you know, memory problems to a very progressive. It goes in this slow, insidious step-like pattern or stage-like pattern. Now, oh yeah, let's ask this question first. Hospitalized and in the 4th stage of Alzheimer's, when a client's asked about the evening, they describe a wonderful evening that they spent on a cruise. Which symptom does this client experience, or what symptom is this client experiencing?
Confabulation.
Confabulation. We just talked about that. We talked about aphasia, apraxia, and we talked about delirium. Okay, so we kind of talked about this. We're going to say it again. Major neurocognitive disorder due to Alzheimer's. Big things to remember about that is that onset's going to be more slow and insidious. Again, it goes in this progressive deteriorating form. Those are some of the distinguishing factors of the Alzheimer's. And another big thing is the etiology. So what's happening that's going on that predisposes my client to developing Alzheimer's? Well, they found out there's some acetylcholine alterations in these clients that are predisposed to Alzheimer's. Now, acetylcholine's in your brain. What do you think is going on in the brain of somebody with Alzheimer's? Do you think they have too much acetylcholine or too little acetylcholine? Which one? Too little acetylcholine. Too little acetylcholine. What about plaques and tangles? Think they have A lot or a little? A lot of plaques and tangles. What about head trauma? Somebody who's had repeated head trauma over the years is more predisposed and more likely to develop, and they've actually studied it that if you have repeated head trauma over the years, you are at a risk for developing Alzheimer's.
So like with those football players?
Football players or fighters. And then genetic factors as well. So first we have acetylcholine ulceration. So the enzyme that's required to produce acetylcholine is dramatically decreased. And so they don't have enough acetylcholine in their neurologically in their brain. They don't have enough of that neurotransmitter. Plaques and tangles, they have an overabundance of these structures called plaques and tangles in the brain. Head trauma, if you have a repeated head trauma, years later, these clients have also developed Alzheimer's. And then genetic factors is another big one. Genetic factors, the genetic role in Alzheimer's is very prevalent, and if you're going to also develop Alzheimer's, if you have a family history of it, it does increase your likelihood of potentially having it. There's 40%, as much as 40% of patients with Alzheimer's do have a family history of somebody else having Alzheimer's or a neurocognitive dysfunction resulting from something else. With the familial Alzheimer's as well, you'll see these clients will typically have an earlier age of onset of Alzheimer's. So like your younger population that develops Alzheimer's, as opposed to the later onset, later in life ages, or those age, that's could be from the other reasons, whereas if they develop it early on in life, it could be more of a genetic, and that tends to be how you see it sometimes, or more often than not, I would say, from what I've read. I do know one of my husband's best friend's dads just died of Alzheimer's within this last year from COVID, but he had progressed through the stages, had strong family history of Alzheimer's, and he got diagnosed at the age of 54 or 55, so young. And then before he turned 60, was already to a point where he was unable to work, got very confused about driving home, doing things that he was very capable of doing, and then got worse when he got COVID and did pass away from it. But again, genetics played a role in that, and early onset cases are more likely to be familial. Okay, let's keep talking. So now let's go back to the second stage. What change would you observe of somebody in the second stage of Alzheimer's?
Memory disturbance.
Memory disturbance. Good work. Okay, so you can also have a neurocognitive disorder that's not due to Alzheimer's. Sorry. You can have it as a result of vascular problems, so as a result of basically the blood flow impairment. Anytime you have blood flow impairment in your brain as well, you can develop a neurocognitive disorder. So what you need to think of with this is what's going to cause there to be blood flow impairment in my brain. And the first thing I think of are strokes, right? So yes, somebody with a lot of mini strokes, if you have a history of mini strokes, you can have a vascular neurocognitive disorder where this just affected so many little spots in the brain that they have variable symptoms that depend on where the alteration is specifically in the brain with what's going on. What differentiates vascular from Alzheimer's is it is going to be that more abrupt onset with vascular as opposed to that slow, insidious, progressive process. And then again, it's going to be a more variable course because it depends on where the impairment is as to how you are neurologically responding to it. Again, I'll just repeat this just for making sure I've made it clear. The cause of your vascular neurocognitive disorder is directly related to an interruption of blood flow to your brain. Various diseases and conditions that interfere with your blood circulation have been implicated. So not only strokes, but hypertension, right? When we have a prolonged state of hypertension in a patient or a client who has hypertension, especially that's unmanaged, they can have a lot of damage to the lining of their blood vessels. And over time with that damage, it can rupture those blood vessels, you can have subsequent hemorrhage, and then you can have inhibited blood flow occurring as a result. You can also have those multiple small infarcts or mini strokes or silent strokes, or you can have one major stroke that leads to, or that occurs in one specific area of the brain. So again, more variable with a more abrupt onset. You can also have a neurocognitive disorder due to a traumatic brain injury. These are, people who potentially have been involved in a serious car accident or some type of accident. You'll see these in your younger population more so as being the cause of why some of them have a neurocognitive disorder as well. Again, dysarthria, we talked about, did we talk about dysarthria? What does that mean? We didn't say dysarthria, I guess. What's dysarthria?
If I had to guess something, joints maybe?
Slurred speech. That's what it is. But yeah, that sounds like it would be. That's a good guess. But yes, it's when you have that slurred speech, you can't really articulate your words. It all just sounds slurred. A lot of times, and we'll kind of go over this when I talk about assessment, but when you hold up, when I'm assessing a client, especially in the ER, when speech gets involved when they're admitted, they'll hold up these papers that have these like little quick phrases that you want somebody to read back to you. And when they read it, you can tell, are they reading it clearly, are they reading it slurred? Or if I'm pointing to a picture of a fork, can they identify that it's a fork and say that it's a fork? Or can they not get that out even though they know what it is and they're trying to find that word? That's not really dysarthria, but I was kind of jumping ahead and like how you're going to be distinguishing, what your client potentially may have. What about ataxia? What's that? Impaired coordination. Like you think of when you're like, I think how like they taught us in nursing school as like you're raising your hand for a taxi because you can't drive, because you can't walk, because you've had too much to drink or something. So they're impaired coordination, not able to coordinate, lose coordination, or impulsivity. All right, there's also neurocognitive disorders that can be due to Parkinson's. Neurocognitive disorder is observed in as much as 75% of clients who have Parkinson's. So that's a significant amount. So I tried to highlight just a few that are more commonly seen. You can also have it due to a neurocognitive disorder due to HIV or due to substance-induced. Can be a predisposing factor to, or can lead to the development of a neurocognitive disorder. With your substance abuse, neurocognitive disorders, your symptoms are going to persist longer than that duration of usual intoxication or within the usual time frame of withdrawal symptoms. They'll persist after that. And then there's also a ton of other things that can predispose that I'm going to list for you. So I just want you to see basically that you can have neurocognitive disorder as a result of many different types of things. There's not just one or two things that can cause it, but a lot of different things can cause neurocognitive disorders, either in a mild or major form. All right, what about this question? Which statement is true about vascular dementia?
B.
Does everybody agree? Yes, that makes sense.
D.
D. So which D is correct. Which ones are describing Alzheimer's? And I said dementia on here, or this question says dementia. It should say vascular neurocognitive disorder. Which ones are describing Alzheimer's? B and C, right? Plaques and tangles. You're going to see that in the brain of somebody who potentially has Alzheimer's, and then Alzheimer's, again, more gradual and progressive. Whereas remember that vascular, the variably vascular.
So vascular isn't the one like we just talked about with the blood vessels and all that?
It is.
Oh,
Did I say something wrong? Or I could be.
I guess that's why I chose, B. I'm trying to see how.
Plaques and tangles in the brain. Well, remember I told you those three things specifically for Alzheimer's. They'll have more plaques and tangles. They'll have more or less acetylcholine. And what was the other thing that I said? With Alzheimer's. There's three things. Genetics. Right? They have that genetic. Or what else? I said more than three, didn't I? Head trauma. There we go. I know I said four. Head trauma. So yeah, any kind of repeated head trauma is also one. And then the vascular, think of more stroke. I think of stroke and high blood pressure with those particularly. Okay, so let's talk about the nursing process, what you're going to do in your assessment of your client with the delirium or neurocognitive disorder. The client history is going to be big and is going to be very relevant in your assessment. And so you want to ask a lot of questions. And when you're asking your questions and talking to them, you're also seeing cognitive changes potentially in how they're answering questions or language difficulties with how they're answering questions, seeing if they're oriented to person, place, or time, seeing if they have that recent memory intact or remote memory intact. And also seeing, like I told you, a lot of the neurocognitive disorders are due to another medical condition. So seeing in their assessment, do you have a history of Parkinson's? Do you have a history of family history of Alzheimer's? Do you have a family history of, somebody in your family having Alzheimer's? Do you have a history of HIV? Do you have a history of a substance problem? Do you take medicines? What kind of medicines? And then physical assessment. Physical assessment with your neurocognitive disorders obviously is going to be more focused on the neuro aspect, right? But also with your, not just with neuro, but that also involves coordination with your arms and legs, and with muscle strength as well, and sensory perception. A big thing with sensory, guys, is make sure you're telling your client when you're assessing their sensory, is tell them to close their eyes and then you feel. Or you ask them where they feel you touching, or where they feel a prick, or if it's sharp or dull. Like you can also assess, have you ever seen somebody, they say stick your arms out, close your eyes, and somebody's arm will kind of wander away potentially, if they have had a stroke or something like that. And then squeezing their hands, for muscle strength, and then push on my legs. Language skills, like I said, to see if they can read you back a sentence. See if they can articulate the words correctly too. Like if they, identifying a hammock. I know there's a picture that always goes around that has a hammock on it. And you ask them, can you tell me what this is a picture of? And some people know it, but they can't find that word of what it is. So that can tell you a lot about where their neurological status is and how their brain is functioning in that way too. Also, you're seeing their behavioral changes too. You're seeing if they're agitated or being more apathetic, or what kind of behavioral things you're noticing as well in your assessment. All right. Also in your assessment, it also includes some blood and urine tests. Again, you're seeing if any of the things that could possibly cause a neurocognitive dysfunction are present. And there's diagnostic exams as well, like an EEG, that's going to show you your brain activity, the electrical activity in your brain, your CT scan. Obviously, you can do a CT scan to show your size of your brain, the shape of your brain. An MRI can be done as well. PET scan's done a lot in diagnosing Alzheimer's. And then you'll see lumbar punctures done to look at the CSF if they think infection might be a cause. So that could be something done as well in your assessment phase. Again, trying to diagnose and see what's going on with your patients. Now, as far as the nursing diagnosis or outcomes that you're looking for, you're going to use your information that you've collected in your assessment to identify some diagnoses and outcomes. But look at a lot of these. A lot of these are going to be risk and safety related things. And then a lot of these that you'll see is going to be, what you're going to do when you're planning care for them as well. I just wanted you to see some potential NANDAs that, would be associated with neurocognitive disorders and delirium. And then, okay, so outcome criteria. Client has not experienced physical injury. These are things that you're trying to get that are realistic for clients with neurocognitive disorders. I think that's all I'm going to say about this. A lot of these, though, again, are focused on that safety aspect as well. And then with help with those self-care deficits. Okay, and then some more of our goals and interventions. So how we're going to implement and carry out some of this stuff. Let's talk about these for a second. For an agitated client, what are we going to do? What are some of our goals of care? What are interventions we're going to do for somebody who's agitated?
Maybe like some distraction or sitting with the patient.
I like distraction. Like that sometimes is the best. If two people are arguing, especially like if they're agitated and they have Alzheimer's, a lot of the times the best thing to do is just to distract them with something else to get them off of that. But what else? I like distraction. That's a good one. What's another one? Reorientation, depending on what's going on or where they are, or like what kind of neurocognitive disorder they have, depending on if they have, sometimes, you can try to reinforce reality all you want to your client with Alzheimer's, but that's not going to help them or calm them down in any way. But depending on what they have, that could help some clients, yes. Medicate them. Sometimes they do need, even like sometimes when you medicate, it's called that chemical restraint. But it's, again, for that client's safety and for the safety of others around them. May have to mechanically restrain them too, for the safety of them and for others. Get them to an area of low stimuli, calm in your interactions with them, clear, simple. What about for somebody who's wandering? We kind of talked about wandering already. So what are we going to do as a nurse? What are some of our things that we want to try to do with somebody who does wander? We said maybe keep them close to the nurse's station. Lock doors, keep the doors closed if they're at home. But in the hospital, if they're there, what else can we do?
Bed alarm.
Bed alarm, like it. Should we keep them focused maybe on something else? Have them on a structured schedule. Have them things to do. Give them a puzzle if they enjoy puzzles, crossword. Keep their mind occupied with something else. And then, make sure they have a safe and enclosed space to walk around or work around. So what about somebody who needs to, if you are trying, what if one of your goals is to keep them reality oriented? What are things you can do to help achieve that goal of reality orientation?
I don't know if this is right, but maybe like get them to, can't they remember the past well? Or?
Remember what? The past? Some of them can. You could, okay, I like where you're thinking. Okay, we can say like, you could give them a picture of like their family and say, who's this again? Tell me who this is, who's this? That can be something that helps reinforce reality, having them have familiar things around, like familiar pictures of people they know. What else? Talking about things that they used to do. What else could reinforce reality? Big things like having a clock in the room so they can look at the time and see what time of day it is. Have a calendar in the room. See what day of the week it is. See what month we're in to help reinforce where they are. Again, make sure they feel safe and protected as well. If they need stuff like from home that keeps them feeling that way. What about somebody who's having delusions or hallucinations? What's something you as a nurse do if your client, what do you do as a nurse if your client has delusions or hallucinations?
Like, I guess you can say like, you understand, like you can say something like, I understand you see this on the wall, but I'm not seeing that.
Yes, okay, so I like how you're wording that. You're doing good of the therapeutic communication. But yes, you don't reinforce it. You do tell them, I understand that that's what you're seeing, but that's not there. You do reinforce real people, real situations, real things. Like, I know you think you see this, but it's just me in here. It's not, nobody else is in here. You do not want to promote that delusion or hallucination. You do want to reinforce them with real stuff, real people, real situations. You do also want to make sure they feel very safe and give them reassurance that they're safe, and do provide words that reassure them, that they are in a safe environment. But again, you're not going to encourage the delusional thinking, but you are going to try to help them focus on real people, real situations. All right, what about if somebody cannot communicate, if they have impaired verbal communication? What are our goals of treatment? What are we going to try to do as a nurse? I've already given you, I think, a couple of examples of what we could do. What are we going to do for our client?
Maybe like find a way for them, like hold up a picture.
Have them something, give them the way to communicate. Give them something if they are able to write or that they could point to, like a picture. All right? Maintain a consistent method for them to communicate in some way. Also make sure they know that you're not like rushing them, that you do, be patient with them when they're communicating too. A lot of times it gets so frustrating for them too that they can't tell you what they want to tell you, but making sure that they know that you're patient and that you're not trying to rush them. What about the goals for treating somebody with a self-care deficit? What would a goal be?
Make sure their needs are met.
Make sure their needs are met. Activities of daily living, make sure you've met those needs. Or make sure, if they can do some of them, then hey, let's, let them assist with the ones they can assist with, and then also fulfill the ones that they cannot fulfill. Okay, let's keep going. All right, so another big thing is going to be education is going to be so important with this. Not only educating the family, the patient or the client, and educating them on, different things, but educating the family is going to be so important because they're going to be the ones that are going to be caring for this patient. It's vital to educate the family members who might be taking care of the client. And also understand that it can impact them and on their state of being and on their mental state as well. Caregiver role strain is a big thing. It's a very, it's a full-time job to care for somebody full-time. So you need to make sure in this education that you're not only teaching the client and their family ways to keep that client safe, how to maintain reality orientation like we just talked about, how to give them assistance with activities of daily living, how to manage those difficult behaviors, why is it important to take our medicines, what are our medicines doing, but also make sure that you're assessing like the financial struggle that might be imparted on the family member from this disease process or from the family or from the client, and make sure they know there are support services for financial assistance for them to just have a support group to go to, and that there are different resources and avenues like home health and all that they can seek out to know they're not alone. All right, and then in the evaluation process, again, this is when you're figuring out, was my goal and intervention successful? Like you're asking the questions of, You know, was that client able to fulfill his basic needs? You know, did I achieve that? A lot of this is going to be, a lot of your evaluation phase is going to be evaluating those short-term goals and evaluating, are we slowing down the progress? Are we maintaining them at the best quality of life they can have? All right, so let's talk about some of the medical treatment modalities for delirium. The biggest thing with delirium is that first one, determine what's going on. Our first step in treating delirium is identify the causative agent and resolve it and correct it. But while your client is experiencing delirium, you also want to make sure somebody's with them so they're not alone, so they do feel safe. Again, that low stimulus level will help with that delirium state as well. Now, some physicians won't prescribe any medicines because, you know, to them, you know, that's just worsening that brain functioning, or it could potentially worsen the brain functioning. But sometimes you'll see some low-dose antipsychotics given. Again, be mindful that everything with your elderly population is going to be more high risk. They're already in that high risk category for adverse side effects of medicines. The benzos you will also see commonly used with substance withdrawal. I know I've seen Ativan used a lot if somebody's delirious from substance withdrawal. And again, every time you think of these medicines and if they are going to be used, think of what we know. Like, what are we going to monitor for somebody if they're on a benzo? You know, we're going to tell them to not DC it quickly. Watch for those sedative effects of them. For our neurocognitive disorders, again, with them, we're going to focus on what the etiology is and then see if there is if it is a potentially reversible process, and then treat it that way. But depending on what's going on, have y'all heard of any of these medicines that are listed below? Yes? No? Which ones have y'all heard of? Namenda. I feel like everybody's heard of Namenda, right? It's one of the newer medicines. What's it used for? Typically, that you see. People who have what?
Somebody say dementia.
Not Parkinson's.
Did somebody say dementia?
Somebody over there did.
I can't hear y'all. Yeah. Well, that's dementia, but not dementia. You know, neurocognitive disorder, Alzheimer. I've seen it for Alzheimer's. But for any of those people that have problems with their memory, you'll see a lot. I've seen Aricept too. I don't know if we're kind of going away from Aricept, but you used to see a lot of Aricept. Do y'all not see it? Do y'all see Aricept sometimes?
I've heard of Aricept, but I just didn't know what it was for.
Those are really the two that I've heard and seen being used. I mean, the other ones I can maybe, not very often. But with some of these, and with the ones for Alzheimer's, I know the first one, this Delirium, is also used for Alzheimer's, neurocognitive disorder due to Alzheimer's. But a lot of these, think of our process of Alzheimer's. If it is used for Alzheimer's, our process is, or what's going on, a lot of times you have a decreased acetylcholine. And some of these are acetylcholinesterase inhibitors that are going to increase our acetylcholine and therefore hopefully improve our cognitive function by increasing the amount of acetylcholine that's trying to be diminished with the process of Alzheimer's. But I really just want you to remember the Aricept and the Namenda. Those are the two that I want you just to think of that you'll see more typically, or that I've seen more typically. Namenda has been approved for the treatment of moderate to severe Alzheimer's. It's been shown to also improve cognitive function and the ability to perform ADLs in clients with severe Alzheimer's. So it has some good stuff associated with it. Okay, so let's talk more about, there are also some medicines that could potentially be given for clients with neurocognitive disorders who are experiencing agitation or aggression or those hallucinations. And those are the 4 medicines you typically will see prescribed for that. What are those type of medicines? What category do they fall in?
Would it be the anti-X? I can't pronounce.
What are all these? What category of drugs are these? Mood? What's the category? Are they? Do you remember?
Is it the SSR or something like
Anti what?
that?
Is it the anti-X something?
Antipsychotics. That's easy, right? Atypical antipsychotics, more specifically, right? These are our atypicals, right? Again, because they're causing fewer of the anticholinergic and EPS side effects than the older antipsychotics. But see that black box, or that last bullet point, it's got, they have the black box warning. So again, although historically physicians are prescribing these medicines to control those symptoms, you do have to use them with caution, because in your elderly population, again, it has been discovered that they could potentially cause more harm than good. So use with caution, but sometimes they're needed and you will see them being given. Have y'all seen Geodon being given? Yes? Seroquel? Risperdal? Okay. I was just seeing how much y'all seen something. Alright, so what medicine out of these would you think somebody with dementia or Alzheimer's is prescribed? Aricept. Aricept. Again, your Seroquel is going to be your antipsychotic. Your other one, the first one, the Pamelor, is going to be a tricyclic antidepressant, and then the Sonata's for insomnia. Again, I'm not going to ask you a specific question per se like that, but I do want you to be familiar again with Aricept and Namenda for Alzheimer's. Why am I talking about depression, and why am I giving us pharmaceutical agent for depression right here?
Because you said it's easy to confuse depression with Alzheimer's.
Yes, and if they do have depression with their neurocognitive disorder, the existence of depression only will complicate and worsen that individual's functioning. And we did say depression can be difficult to distinguish from neurocognitive disorders, but its existence with a neurocognitive disorder is going to just worsen how they function. So we need to also know what we are going to do to treat their depression if it is relevant or if it is present. So SSRIs, again, are our first lines. Our tricyclics, we're not going to really try to use those because, again, of those anticholinergic and cardiac side effects that they might have. I'm not really going to talk about the other two because I'm not going to touch you on those. Also, we have some medicines for anxiety. Depending on what we're trying to do, or how severe of what's going on, depends on which one we're going to use. Ativan you see used a lot. Again, it has a shorter half-life, so it's used commonly in the hospital setting. Valium, though, also has a little bit of a longer half-life, so you will see that one too. But I'm not really, I'm not going to ask you a lot of specific questions on these drugs. I do want you to look at them enough where you start getting familiar and identifying them as anti-anxieties. That I know that Xanax and Valium and all my PAMs are anti-anxiety medicines. And then there's also medicines that they can give for sleep disturbances. Again, short-term therapy only, but you will have clients as they progress in their neurocognitive disorder, they might have problems sleeping and staying asleep. So some of these medicines might be indicated for them. But again, some of them can cause that daytime sedation as well. All right, that's all I'm really going to say as far as our neurocognitive disorders go. What y'all think of neurocognitive disorders?
More interesting.
I feel like it's, I enjoy teaching this part a little bit more. Mental health, like I told y'all, has never been, I mean, I've learned to appreciate or just understand it more, which I think is helpful too. The more I've had to teach it, but, it is something you'll see, and now that, you've learned about it too, when you see clients, you'll start identifying some of these things and some of these qualities more often, and, kind of know more so how to treat them more appropriately as well. Okay, so next week we're gonna hit anxiety and some of the OCD disorders. And then I think what I'm gonna do, guys, I'm gonna just pre-record and have it available, maybe if I can, for you, the rest of it, so you can just study it if we don't get to it in class on Monday. Because I don't want to try to rush through everything, but I also want to make sure I've covered it all. So I might pre-record some of that, so y'all can have that, so we won't be rushed. Again, you can look through. I do want you to have, I hope that it's not going to be the first time you'll look at those slides on Monday when we go over them. Because I do think, you should be kind of looking at it and getting a quick peek of it beforehand. It also helps you retain information more if you've looked at it before class. But our test is going to be on Wednesday. If you haven't turned in your ATI stuff, there's 3 separate ATI assignments that will be due before the test for mental health, community, and mental health, community, and communication that are all due, okay? If you turned them in already, a lot of them I've already graded. If you didn't receive all the points, look at why you didn't and go back and correct it if you can before the due date, so you can get all the credit for your assignments, okay? Y'all got questions? Comments? Yes?
Once we finish class, can you walk us through this pump for a quick second?
Surely. I can.
We stayed up here like an hour yesterday trying to figure out one thing, and we had all kinds of issues.
Oh, really? Well, then, let's look at it really quick.
Air.
So this is the Delirium, which you'll have in